So I'm going to, I think Matthias has really set the basic stage very nicely. I'm going to take now a more sort of applied or translational approach and sort of give an overview of how we go about imaging these processes. I'll touch somewhat on targeted and molecular imaging, but also keep it general. And I should disclose, I do get, well, there's my disclosure. Okay, so as Matthias very nicely went over, the survival of acute ST elevation MI has improved from about 60-70% to over 95%. But we've created a new disease, and largely it's this: heart failure because of inability of the heart to pump. We call that heart failure with reduced ejection fraction. It's not exclusively caused by coronary artery disease, but about 2/3 or 70% of cases of heart failure where the heart is not pumping adequately is due to coronary artery disease. And what's happening there, when we refer to coronary artery disease, we mean myocardial infarction, and what's causing myocardial infarction, as Matthias referred to, is rupture of a vulnerable plaque. That then leads to an acute coronary syndrome or an acute MI. That's followed by left ventricular remodeling, which Matthias talked about very nicely, and heart failure. I should mention, just for completeness, in the last decade or two, there's been a realization that there are really actually two flavors, two forms of heart failure. And about 50% of patients presenting to the hospital with heart failure, with signs and symptoms of heart failure, actually have a preserved ejection fraction. And we call this HPEF, heart failure with preserved ejection fraction. And this is a much harder syndrome to define, diagnose, and treat. And so I'm just going to make my job easy and focus for the rest of the talk on this one over here. One could really have an entire session on this condition alone. So the question to us then is, how do we image and intervene in this cascade? Detect vulnerable plaques, prevent acute coronary syndromes. If an acute coronary syndrome happens, how do we prevent ventricular remodeling? Matthias alluded to that very nicely. And ultimately, how do we prevent heart failure? Oop, did not play. Okay, played in the speaker ready room. So then I will just skip this slide. Well, here are examples of human coronary arteries. These were post-mortem hearts. The donor, the hearts were rejected from transplantation because of coronary disease. And here's an example of fibro-calcific plaque. This is a human coronary artery. Here's some fibro-calcific plaque. Here, cutting it in its short axis. And how do we know it's fibro-calcific? Well, we use a combination of MR contrast mechanisms, T1 weighting, and then this one in particular known as ultra-short TE MRI. And putting the two together allows us to have a very specific tissue signature of calcified areas. Now, as happens actually that plaque calcification, particularly if it's diffuse, tends to stabilize plaques. So these are the plaques that actually worry us less. It's possible that this plaque will expand over time and gradually occlude the vessel and cause angina, cause symptoms, cause chest pain. But this sort of plaque will not lead to an acute heart attack and an acute coronary syndrome. This plaque, however, will. This is a lipid-rich necrotic plaque. So this, again, is a human coronary artery imaged ex vivo at high field. I'd refer you to this paper, anyone who's looking for the details. So what do we have here? Well, we have the vessel lumen. We have this thin fibrous cap that's separating the lumen from this plaque. This plaque is T2 hypointense, so that's lipid. And then these areas of hypointensity are calcium. But we have this very large lipid pool. what happens is that when this fibrous cap ruptures, and Matthias referred to all the inflammatory activity in this plaque, all the monocytes are secreting proteases, MMPs, degradative enzymes that are going to break down this thin fibrous cap. When that happens, the blood is exposed to this highly thrombogenic material, and you get an instant thrombus. So you go basically from a vessel that is a fairly patent lumen. This plaque ruptures, and you get an occlusive thrombus forming in an instant, and that's what leads to a heart attack. So what we really need to do, if we really want to intervene at the most basic level, is to be able to detect these vulnerable plaques and then determine whether we can prevent their rupture. So I've shown you some MR images. Well, how does CT do? So if we take these plaques and we image them at the same spatial resolution, a CT actually doesn't do well, and that's no surprise to us. We know CT has poor soft tissue contrast. It certainly can't characterize a lipid-rich plaque well, and actually it misses a lot of microcalcifications. So MR is actually a lot more accurate for the characterization of plaque. And the optimists amongst you may say, great, well, we have MR. You've shown us some nice images. Let's go ahead. Let's image vulnerable plaque in patients with MR. But there's a little wrinkle, and that's the motion of the coronary arteries, which is quite profound. This is work done by Paula Montesinos, a graduate student working with me. I won't go into it. This is from an abstract she presented recently. But you can see that the motion of the coronary arteries is on the order sometimes of 20, 30 millimeters. So clearly, if we're going to image the coronaries by MRI, we're going to have to overcome this motion problem, and that's not a simple solution. Well, what about CT? Well, we all know that CT can produce lovely coronary angiograms. This is work from the ROMICAT study, in which CT was used in the emergency room to triage patients towards admission or discharge. And you can see over here, they're showing the LAD, the right coronary artery. We have a very nice high-grade stenosis in the proximal LAD. And this is a sort of plaque that would cause someone symptoms, angina, but it's not going to kill them. As we've discussed, it's the rupture of the non-occlusive plaques, which we can see all along these vessels, that lead to that sudden thrombus, that sudden occlusive thrombus. Those are the lethal events. Those are the plaques that cause acute coronary syndromes. So how is CT in detecting those? Well, not terribly good. We've sort of shown that at best the soft tissue contrast, and you can do calcified versus non-calcified, low attenuating plaques versus high attenuating plaques. But when you robustly analyze the ability of CT to characterize a plaque, say, versus histology, it's moderate. There are correlations. It's not that there aren't, but the correlations are moderate. So we have a problem. In CT, which can deal with the motion of the coronary arteries, doesn't have the contrast. MR, which has all this beautiful soft tissue contrast, has a problem with motion. So what can we do? Well, this was a line of work that really was pushed by Ahmed Tawakkal at the MGH, and who's done some really lovely work in this area. It remains still somewhat controversial, but I think it's been extremely important work. And that's to combine PET or fluorodeoxyglucose with CT of the coronary arteries. So as Matthias very nicely showed, that vulnerable plaques are inflamed, they're full of monocytes and macrophages. And we know that monocytes and macrophages have very, very high uptake of fluorodeoxyglucose. So can we use that as a marker of plaque vulnerability? And now what Ahmed did, what Ahmed did in the study was to image people with acute coronary syndromes. They all had stents put in, and you see a lot of FDG uptake there. This is people who had stents due to symptomatic occlusions, but not acute coronary syndromes, and there's certainly suggestion of less FDG uptake. So this was sort of an intriguing study that suggests that maybe FDG could be used to image plaque vulnerability. But if you look at the study, this image, you also see what the challenge is, that you see a lot of FDG uptake all over the place. And that's because the myocardium is incredibly metabolically active, uses huge amounts of glucose, and what's done here is to suppress glucose uptake in the myocardium with an extremely high-fat meal, even worse than the meal I had last night here. It's basically a milkshake of fat. And that's the only way that you basically shift metabolism in the myocardium from glycolytic to exclusively fatty acid oxidation. At least you try to do so. But this is a tough thing to do. It's very tough to suppress background signal due to FDG in the myocardium completely. So this technique has a big challenge in that regard. So the use of FDG still remains controversial. As I say, it's very difficult to fully suppress the myocardial FDG signal. You're limited to the very proximal coronary tree. You have lots of motion, gating, and attenuation issues. I think we'll see where this technique evolves over time. I'm not a PET expert. Most of what I do is MR and optically based, but I think, as an interested outsider, I'd say this is extremely important work. Really congratulate the team who've been doing this. And I think it's important for us to know what the opportunities and what the limitations for this are. So if we look at the landscape at the present time in vulnerable plaque detection, it's not that great. MR, we still haven't fully learned how to deal with motion. The soft tissue contrast of CT is limited, and techniques like sort of K-edge sampling and multispectral CT aren't really going to change that easily. PET-CT with FDG is interesting, but complicated by the limitations we've talked about. So that's sort of the bad news, or moderately bad news portion of the talk. Let's move on to the myocardium now. And there we have a lot of tools that are working well. Matthias showed some of them. I'll show a few more, and I'm sure Pete will show even more than those. So the myocardium is a very nice imaging target. And what's really wonderful about it is we get a very nice contrast during an acute coronary syndrome between infarcted myocardium and normal myocardium. The myocardium forms its own control, the normal areas of the myocardium. And there are a lot of processes that we're interested in. Matthias alluded to cell death, and this can be due to apoptosis, necrosis, or autophagy. The death of cells leads to inflammation with macrophage infiltration, initially the release of cytotoxic, and cytotoxic and proteolytic enzymes, later reparative process such as angiogenesis and collagen deposition, and then also there's an interest in imaging regeneration. So it turns out that actually there are probes that have been described which can image virtually all of these processes. So let's start off by looking at cell death. This is one of our earlier interests, and in collaboration with Lee Josephson, we developed an iron oxide nanoparticle that was labeled with annexin, which binds to the surface of apoptotic cells. Here you can see we've imaged this with T2 star weighted imaging, so causing signal hyperintensity in the infarcted myocardium, the control probe showing very little retention, and because we have a near-infrared fluorochrome on the probe, we can visualize exactly where it is. Apoptosis is characteristically seen early in ischemia reperfusion, and late on in the injury we see cell rupture due to necrosis, and necrotic cell death tends to dominate areas of the myocardium with poor degrees of reperfusion. And how can we image that? Well, if we think of it, there's a target waiting for us there, and that's the DNA in the nucleus. If we can design a probe that can't get across the cell membrane, but once the cell membrane ruptures, can gain access to the cytosol and then be attracted or then bind tightly to the DNA in the nucleus, then we have something we can use. And that's the basis of a whole panel of fluorescent agents such as propylium iodide, Cytox green, and this agent here, thiazole orange. So again, my collaborator Lee Josephson figured out how to bind gadolinium to thiazole orange and prevent its uptake by by serum albumin, but still maintaining very high specificity for DNA. And this just shows some simulations of how the GAD-labeled thiazole orange will intercalate into double-stranded DNA. So if we look now at again, this is a mouse model of necrotic cell death. So we're including the coronary artery and not reperfusing. So we get a lot of cell rupture, a lot of necrotic cell death. That if we give this agent an image about 2 hours later, we see very strong retention of the gadolinium thiazole orange, whereas non-targeted gadolinium will wash in. It will show the late gadolinium enhancement effect that we see between 20 to 40 minutes, but really within an hour of the infarct of injection, it's all been washed out, and we see nothing. And again, because this is a fluorochrome, or this is a fluorochrome lanthanide complex, we get both an MR signature as well as an optical signature, and over here we've just co-stained with DAPI to show that this agent is indeed binding to the exposed nuclear DNA after cell rupture. And this can be, if one does a time course or time series of this, one can actually get a very nice readout of of the evolution of cell rupture in an acute infarct. And it turns out that it takes some time for the cell to evolve, for cell rupture to evolve. The peak of cell rupture is seen about 10 to 20 hours after infarction. And interestingly, this corresponds to the time that we see troponin become positive in the bloodstream. So it all depends how, what tool you look with, but certainly if you look for macroscopic or rupture in the cell membrane that will allow something that's sort of 1500 kilodalton in, then that takes hours. So again, we may have a window of opportunity where we can try and intervene. So the third form of cell death is this thing called autophagy. And for the Greek scholars in the audience, that just means to eat oneself. So this is a process whereby a cell digests itself. It digests dysfunctional organelles, dysfunctional contents, particularly mitochondria, within the cell itself. It's been known for a long time that something known as rapamycin, which inhibits something called mTOR, is a very strong inducer of autophagy, and that's what we used to try and see if we could image this process. And what we used is a cathepsin activatable fluorochrome, because during autophagy, what happens is the contents of the cytoplasm are trafficked to lysosomes and digested by cathepsins there. So this is work by Howard Chen, who showed that with ischemia reperfusion alone, you get no fluorescent signal, but once you add rapamycin, you get a very nice signal due to autophagy, which imaged there ex vivo, and then in collaboration with Matthias, imaged in vivo with FMT. And you can see, again, very specifically when you add the rapamycin, you get the signal within the heart due to autophagy. So this is a tough nut to crack. Autophagy provides very few targets to image. This, as far as we know, is the first sort of probe-based approach to image autophagy. There have been a couple of transgenic animals described and surface-based fluorescence approaches. But this is an approach that can be used in any animal, or any small animal at least, and will allow autophagy to be imaged in deep tissues. So, and the last point is there's been some debate, at least within the cardiology literature, is autophagy protective or deleterious? And Howard showed very nicely in this paper that it actually is protective and decreased infarct size by up to 40%. The reason that's happening is we think autophagy is removing dysfunctional mitochondria from the cytoplasm into the lysosomes and preventing those dysfunctional mitochondria from triggering apoptosis. Dysfunctional mitochondria are an extremely potent stimulus of apoptosis, and their removal via autophagy basically reduces apoptosis in the cell, which Howard showed very nicely over here. So after cell death, we get inflammation, as Matthias talked about, and this can be imaged with a variety of tools. Most have been nanoparticles. This is an iron oxide nanoparticle, cross-linked iron oxide, just showing via its optical signature, the uptake of this agent by macrophages. And of course, it can be imaged by MRI, both using T2 star-based approaches, which produce signal hyperintensity, and then phosphorescence approaches, which produce positive signal. And this correlates very nicely with macrophage content in the infarct. And you'll see the remote, obviously, the remote zone forms a very nice control. This is work out of UVA, and what they used was a liposome loaded with gadolinium to image macrophage uptake in the infarct. Over here, just showing an R1 map. And I think in a very elegant way, correlated this readout with circumferential strain in the infarct, showing again the power of molecular MRI, the ability to put a molecular readout and a functional readout together. And then there's been a lot of interest in using fluorine F19 labeled liposomes. So those of you who do PET are used to using F18. Well, F19 is in the drinking water and certainly has some very nice magnetic properties, polarization that's very high, alarm frequency that's quite similar to protons. So it can be imaged in conventional MR systems. And this is work out of Düsseldorf originally, now used by many groups, taking liposomes, packing them with fluorine 19, because you do have a sensitivity issue there. You need a lot of fluorine there to detect it, F19 that is, and then imaging the same signature in the infarct by MRI. Now, the work I showed you has all been preclinical. It's all been done in mice. And obviously, there's an interest in translating this into man. And just a couple of points to make there. That the blood half-lives of nanoparticles in mice and men are very different. That mice have very high metabolisms, very highly active reticular endothelial systems, and the blood half-life of nanoparticles in mice tends to be much, much shorter than it is in humans. Now, this is important in the myocardium because the vascular volume fraction in the myocardium is about 10%. You have a highly, highly vascular organ. So if you have a lot of background probe floating around in your blood pool, because of that high vascular volume fraction, it could lead to a lot of noise in your image. So you really want to wait 5 blood half-lives after you've injected the probe to make sure that all that probe that's floating around in this very high vascular space in the myocardium is washed out. So it's important to know what the half-life of your probe is in mice, what the blood half-life of your probe is in humans, and adjust the time that you acquire your images accordingly. The other very important point is that not all nanoparticles are the same. That the uptake of nanoparticles by macrophages will be driven in large part by size and also by surface coating. So for instance, macrophages tend to take up, pardon the typo, dextran nanoparticles far more avidly than carboxymethyl dextran nanoparticles. So these are factors that you have to take into account when designing or interpreting or translating studies that have been done in mice into humans. And I mention this because we saw a nice study, or actually a couple of nice studies last year come out in which now clinically approved nanoparticles, in this case spheromoxetol, was used to image inflammation in patients post-MI. Here you can see these are R2 star maps, a patient given no probe, below a patient given probe, and you can see how the R2 star changes in the infarct, again, presumably due to the uptake of the nanoparticle by by infiltrating macrophages. Matthias mentioned very elegantly and discussed how what he likes to call the yin and yang of macrophage infiltration, their pro-repair role, such as in angiogenesis. This was work out of Munich, using Galacto-RGD to image angiogenesis in the infarct. And I think we see some interesting data, but And I think this is ongoing work. One of the challenges of RGD is obviously it's an integrin imaging, very widely expressed target. It's on immune cells. It's on virtually any moving cell. A very widely expressed target, but this was certainly a very intriguing preliminary work. And this is work from Al-Sanusis' group with actually a SPECT agent to matrix metalloproteases. MMPs are secreted by the infiltrating macrophages, break down the matrix, lead to the infarct expansion that Matthias talked about. So what they did over there was to use thallium as a perfusion agent, this agent which binds to MMP to show MMP uptake in the infarct, fusing them over here very nicely. And obviously the hope is that this could be used to guide and tailor the modulation of the immune system Matthias talked about and of MMPs. And then Matthias alluded to imaging of myeloperoxidase with a activatable gadolinium probe. This was developed by Alex Bogdanov and John Chen. And you can see over here in wild-type mice the secretion of the peroxidases by the macrophages can be very nicely imaged. And in homozygote knockout mice, no signal. So we're able to image macrophages and both their reparative role, their degradative role, and when the dust settles 3 weeks later and these processes have reached completion, what are we left with? And one technique that we like to use to look at the myocardium is something known as diffusion MRI tractography. This has been extensively used in the brain, and it allows us to look at the myofiber organization in the heart. And what you'll see over here is this is a normal rat, and you can see these very nicely organized myofiber tracks. And here's an infarct 3 weeks after remodeling, and you can see that a lot of fibers have been lost, not completely. It's not a smooth wavefront. There are a lot of residual myofibers that remain in the infarct. That's been known from histological studies for many years. But clearly the infarct zone is very abnormal, and as Matthias very nicely showed, it's a very highly metabolically active area, and our ability to modulate how the scar heals will have a large impact on the patient's prognosis. Now you may be wondering what these color codes are. The fibers have been color-coded by what's known as the helix or inclination angle. So it turns out when I was certainly a medical student, I thought my fibers just, formed, a circle around a cylinder. It turns out it's not the case. If they did that, the heart wouldn't be able to contract. It's only in the mid-myocardium that they're circumferential, and you can see that in the subendocardium and the subepicardium, they're actually fairly orthogonal. They cross each other. They form an array of crossing helices. And one can color code the fibers according to that helix angle. But to get back to the biology, it's not just that there's a lot of activity going on in the infarct. There's a lot going on in the remote zone. So that's the myocardium that wasn't affected by the infarct. And there are metabolic changes, there's apoptosis, and there are structural changes. And that we showed over here. When you take a human heart, a normal human heart, you see the epicardial and the endocardial fibers crossing over each other very nicely. A sheep heart, normal sheep heart, similar pattern. But now the remote zone of an infarcted sheep heart, and you can see those red fibers have disappeared. There's basically been a loss of obliquity in the fibers in the subepicardium that become more circumferential. I won't go into it here. We understand the mechanical reasons for that. But this puts the remote zone at a mechanical disadvantage and is part of that progressive dilation, remodeling, and loss of efficiency process that happens in the heart and leads to heart failure. And that just confirms histologically what we see if you compare to normal myocardium. The remote zone, you'll see how different the angles of the fibers are. In the interest of time, I didn't cover, I think, another very important area, and that's the energetics in the myocardium. And both MR and PET imaging have a lot to offer there. Obviously, in MR, P31 spectroscopy has been around for a long time, particularly the phosphocreatine ATP ratio is extremely prognostic, actually amongst the most prognostic biomarker in heart failure. But this is a tough measurement to make, and really the Oxford group led by Stefan Neubauer and the Hopkins group by Bob Weiss are the two groups, the premier groups doing this. There's a lot of excitement now in the use of hyperpolarized C13 to image pyruvate, lactate metabolism, and really get similar readouts by MR as that traditionally have only been obtainable with C11 PET. And then PET, of course, remains a phenomenal technique to study both glucose and fatty acid metabolism, also sympathetic innervation. And again, anyone interested in this, I'd point you to work from Rob Groppler's group at WashU and Frank Bengel's group. And I think a very nice way that MR and PET may come together is in the domain of imaging energetics, and I'm sure most in the audience are now familiar with the development of simultaneous MR PET systems. This was one of the prototype PET inserts developed in our center by Cyprian Katana and others. You can see the PET insert initially was a head-only insert, went into a clinical 3T scanner. And it allows you to do things like better attenuation correction, motion correction, arterial input function modeling, and really actually does a lot for one's PET image. It allows you to improve one's PET image quite considerably. We're over here interested in imaging the heart, so this PET head insert is limited, but there now are whole body systems that are commercially available where PET and MRI of the heart can be performed simultaneously. So in wrapping up, where are we to go back to that ischemic cascade we talked about? So in terms of imaging the vulnerable plaque, this is an unsolved technical problem. And not just the molecular imaging of vulnerable plaque, the anatomical imaging of vulnerable plaque has not yet been solved. And before one can do molecular imaging, one has to do plain good old anatomical imaging. So this is an area where we still have a lot of work to do and a long journey to travel. Imaging of the myocardium, as I hopefully have convinced you, well, anatomical and functional imaging is standard practice. Molecular imaging is now technically and scientifically very feasible. It's been demonstrated for multiple targets with multiple modalities by multiple groups. And the question is, how do we translate this? And I'm sure there'll be a lot of talk about this at the meeting. We obviously have regulatory challenges, economic and cost challenges, but we are making progress. I showed you some clinical studies published last year with iron oxide nanoparticles. So we've just got to keep bashing on and keep doing what we're doing. Let me end there just by acknowledging the people in my group, some of whose work I showed today, and thank you for your attention.